Today. I'm James Walters, Professor of Psychiatry in Cardiff University in the UK, and I'm co-chair of the PGC Schizophrenia Group. Really glad to be here today and introduce colleagues who are going to talk about some of the findings emerging from really cutting-edge, clinically relevant CNV research and experience, and particularly looking towards the clinical interface and how utility is being exploited for CNVs in this sense, but also hopefully paving the way for wider clinical translational of our research findings. It's really, a joy to be able to do this. This wouldn't have been possible even 10, 15 years ago. The findings and within the kind of neuropsychiatric disorders we're considering have really emerged in that time frame. And for clinical translation to even be a possibility within those times is great to be able to communicate, I think. So without any further ado, we've got three speakers today, each of whom are going to speak for 10, 12 minutes. We'll have questions for each speaker briefly after their presentation, but then are hoping to allow a more prolonged time at the end of the three speakers' talks to field a more general discussion. But please put your hands up at the end of each talk if you wish to speak. And Grace, who's very ably assisted us today, will allow you to speak. And equally, if you want to put questions into the chat as well, then that's fine. So the first speaker is David Ledbetter. David's an American Board of Medical Genetics certified clinical cytogenetics laboratory director. And it's that background in which he'll speak today, but also extensive experience that he's developed in recent years in a field very relevant for us. He's currently professor at the University of Florida College of Medicine in Jacksonville, and he's previously the executive vice president and chief scientific officer at Geisinger, where he led one of the largest genomics and precision medicine programs in the world. And it's going to be a real joy, I think, for people in our field to hear about this work. In the talk today, he's going to leverage data that has emerged from exome sequencing of over 175,000 individuals that determines the prevalence and penetrance of rare genomic variants. And this is chiefly CNVs, but as we'll hear, it extends beyond that as well. And this is a population health system-based population study, but is very relevant for all we're going to consider today. So David, thank you very much for agreeing to speak with us, and hand over to you now.
Sure, thank you, and happy Rare Disease Day to everybody. I'm now at University of Florida, but continue to collaborate closely with a large team of researchers around genetics of neurodevelopmental disorders at Geisinger, and has both a pediatric clinical population, but also, as James has alluded to, an adult biobank called MyCode. And a lot of the data I'll be presenting today comes from that adult biobank, where over 300,000 patients have consented to share their clinical data and donate blood for DNA sequencing. Over 180,000 have had exome sequencing and SNP genotyping. And in one study looking at the American College of Medical Genetics so-called secondary findings gene disease list, including things like BRCA1 and 2, Lynch, FH, and other common dominant diseases. Now over 4,000 patients have had CLIA confirmation and results returned on their increased risk for early onset cancer, early onset cardiovascular disease. We took the same adult biobank population, and we wanted to identify the prevalence, penetrance, and personal utility of identification of copy number variants, or CNV disorders. These are all well described and all associated with neuropsychiatric phenotypes in a significant percentage of patients. So we used a subset of 90,000 patients who had exome sequencing data. We looked at 31 of the best described recurrent CNVs. So these are all segment duplicated deletions and duplications that have been well described phenotypically. And we did CLIA confirmation from the research exome data in order to be able to write reports and return clinical results back to patient participants. So just jumping to the prevalence high-level conclusion, you see 708 CNVs were identified out of 90,000 patients for a prevalence of 0.8%. It seems remarkably high, almost 1%, but it's almost identical to results from DECODE in Iceland, the UK Biobank, and the Estonia Biobank, and I'll show another slide later, that about 1% of the adult general unselected population carries one of these CNV disorders. Importantly, when we looked at the EHR, and Geisinger has a pretty comprehensive EPIC as their EHR, only 6% had a genetic diagnosis documented in the EHR. So 94% of patients did not know that they had an underlying medical condition or rare genetic disease at the time of sampling. We then went to the EHR to look for evidence of CPT codes, ICD-9 codes, 9 and 10 codes, that were consistent with the CNV disorders, focusing primarily on neurologic and psychiatric phenotypes. And 70% of participants who had these CNVs had at least one, usually more than one, clinical symptom consistent with their CNV diagnosis. We then decided, similar to our earlier decision, to return clinically actionable results when we found a BRCA1 mutation, a Lynch syndrome mutation, or an FH or other cardiovascular risk. We decided to take 9 of the best described, best known CNV disorders, and to do clinical confirmation, and then to return these results to these adult patient participants in the biobank. And this was usually done by a genetic counselor or other study coordinator who would call the patients and say, do you remember that you consented to participate in Geisinger's biobank called MyCode? And the majority said yes. Do you remember that in that consent process, we told you that if we found a genetic result that might be relevant to your health, that we would offer to return that result to you? And again, the majority said yes. So that was the case with these neuropsychiatric CNVs. I'll give one patient story, a 48-year-old man who we identified a 22q11.2 classic 3 megabase deletion on 22 that this audience should be quite familiar with. When we called him and talked to him, we found out that he lives with his parents, single, never married. He did graduate from high school, works as a welder, drives a car, and independently manages his appointments and finances. We asked him if he wanted to come into clinic to be seen and to talk to us about this result. And when he was seen in clinic, had a typical facial appearance of 22q11.2 deletion, but no other physical medical problems or surgeries. But he did report to us that at age 35, he had a psychotic episode that required hospitalization. He was stabilized on medication, and then his psychiatrist tried to wean him from that medication, which resulted in recurrent psychotic episodes. When he heard the features of 22q11.2 and understood that this was a chronic lifelong condition, he actually reached over and grabbed the genetic counselor that was in person with him and said, can you please call my psychiatrist and ask him not to wean me from my medication, but keep me on my medication. I do so much better when I'm on medication than when you take me off. So they've now moved to a stable low-dose antipsychotic medication, and the patient's doing quite well. The quote in the lower bottom right of this slide is typical of many of the adult patients we saw again in their 40s, 50s, and 60s who had had lifelong experience with anxiety, with learning difficulties in school, other sorts of problems, that now they had a unifying medical explanation for the behavioral learning and in some cases medical problems that they had had throughout their lives, but were not explained. And this chart shows some of the quotes from patients. I was a slow learner. I knew I had anxiety. I knew I had different things, but I didn't know where everything came from. It was very helpful to learn of my underlying rare genetic disease. It took a lot of guilt off. I think it does change sense of self because I realize there's a medical explanation that's something behind everything. It's not just all in your head. So overall, we found that providing these clinical results back to patients, and in many cases to their parents, since many of them lived at home with their parents still, was received very positive, had a positive impact on sense of self, and medicalized the behavioral learning, anxiety conditions they had dealt with throughout their lives. We also recently published a follow-on study to this where we looked at single gene point mutations shown in the middle as neuropsychiatric disorder genes. And you see in that same adult population with a list of about 94 single genes, 0.3% had clear pathogenic mutations. So if you add the 0.8% to the left in Geisinger my code C and V's to the single gene 0.3, it's 1.1% of all of Geisinger adult patient participants had a pathogenic CNV or pathogenic mutation in a single gene. And I've shown here to the left the decode results in a brownish color, the Estonia biobank in a purple color, and the UK biobank in a pink color, all hovering around 1% of the adult population has one of these underlying rare genetic diseases. We followed this up with an analysis of healthcare utilization among my code participants who had these copy number variants, looking at almost 1,000 adults with neuropsychiatric CNVs. We found a much higher rate of neuropsychiatric diagnoses in the EHR compared to controls, but really interestingly and importantly, a greatly increased risk of other chronic diseases, including a twofold risk of diabetes, twofold risk of dementia, and very importantly, more than a twofold increase in emergency department visits. So we hope to continue to develop data from this cohort to demonstrate to Geisinger Health Plan, as well as other insurers, that identifying these underlying genetic conditions increases the opportunity to monitor and manage the conditions, treat them, and try to decrease healthcare utilization, and particularly emergency department visits. So I'm going to stop there and acknowledge primarily my co-PI, Krista Martin. She and I have had a joint research lab for over 25 years, and you see the members of our research team, most of whom are still at Geisinger, and as well as thanking the patient participants from Geisinger for allowing us to do this work. So I'll stop there and take questions, James.
Excellent. Thank you, David. That's really great, and an overview of a really exciting and already productive project. So thanks very much. So any quick questions for David at this stage about what he's presented before we get onto the general discussion at the end? As I say, either put them in the chat or raise your hand.
Chaumette's hand up already.
Excellent.
Hey, David. Great talk. So do you have any recommendations or thoughts as to how this would be used for personalized medicine? If you had this information 10 years earlier, what would you have done differently?
Yeah, so Ann Bassett is the best one that I've heard as a clinician talking about 22q11 deletion particularly. And the question raised, would you want to know earlier in life, even in the neonatal infant life stage? And she says, as a psychiatrist, absolutely yes, to be able to manage the patients and to monitor them closely and try to prevent the first psychotic episode. So the critical thing is to avoid that initial psychotic break or psychotic episode. Not being a clinician myself, I don't have the experience to comment beyond that, but I think Anne and some of the other clinicians in this audience may be able to answer that question better.
And I think, Kim's talk, which will come next, is probably relevant to that question as well. So thanks, Jonathan. Francis McMahon. Francis, welcome and take your question.
Hey, David, thanks so much for a fantastic talk, as usual. And we follow your papers very closely, as you know.
Thank you.
And as you also know, as a member of our genetic testing task force over several years, you participated in discussions about whether the ISPG should recommend an exome sequence with copy number variation detection for adults with psychiatric disorders. And all the backs and forths we did over that over the years. With this new data that your group has produced and others as well, do you think that there's now a stronger case for advocating that, or is it something that should still be reserved for only selected patients?
Yeah, so it's been approved by Geisinger Health Plan for several years now, maybe 3 years, to do adult psychiatric patients and do exome sequence with CNV calling. So as this data was developing, we informed them and they have approved insurance payment for adults in this category. I think the data has been fairly compelling for several years and it should be recommended. And one of the key features, which is a little bit hard to objectify, is anytime there's a cognitive impact, and not just meeting full criteria for ID, but IQ in the low normal range, lower than the parental or family background or expected IQ. So all of these CNVs and single gene mutations have a significant 1 to 2 standard deviation deleterious impact on IQ and cognitive performance. And so if the adult patient has a low normal IQ different from family members, first degree family members, that's a huge clue for genetic testing in a de novo mutation.
Thanks.
David, thanks very much. And thanks for the talk. And look forward to you participating in the wider discussion we'll have at the end as well. And thanks for the question. So next, it's my pleasure to introduce Dr. Kimberley Kendall. Kim works in Cardiff University and is an academic psychiatrist and holds a prestigious WCAT fellowship to conduct her research. She's been involved in CNV research since the time of her PhD and has also been at the forefront of translating those findings to clinical practice. So Kim, very happy to have you. Thanks for speaking today and hand over to you.
Thank you, James. As James says, my name is Kim and I'm an academic psychiatrist. I currently split my time between research at the Centre for Neuropsychiatric Genetics and Genomics, where I've so far been working a lot on copy number variants. But 3 days a week, I also work in a community mental health team. So today I'd like to speak to you a little bit about our new service, which is the All Wales Psychiatric Genomics service. I'll then go on to speak a little bit about the dual challenges that we've experienced working at the interface of research, genetics and psychiatry. Some of you may remember quite a while ago, I was working on developing a protocol to return CNV results to NCMH participants. So NCMH is one of our research cohorts. And similar to what David presented, I believe that stories make this come to life. So I'm going to end on a few stories of our patients. So let's start with the All Wales Psychiatric Genomics service, which is a relatively new service and is the first of its kind in the UK. And it really came about because Well, obviously, primarily because of a need to translate our psychiatric genetic research findings to the clinic, but also, and it couldn't really have happened without this, all the major players were in close proximity and ready and willing to work together. So this clinic was set up really because we had buy-in from Medical Genetics and Genomics Partnership Wales. Clinically, we had participation from Cardiff and Vale University Health Board, and then from the research side, both in genetics and mental health research, we had the National Centre for Mental Health and what used to be the MRC Centre. And of course, we've had input from families, patients, all throughout the way, who've helped us to shape the service. So who are we? Well, we're quite a little team at the minute, but we're building up. We've got 2 consultant medical geneticists, Annie and Rachel. Annie, unfortunately, is due to retire soon. Our psychiatry representatives are James and I, and we've got a principal genetic counsellor called Donna Duffin. Most of our lab work is done by Dr. Jade Heath, who's a clinical scientist, and then her head of section is Chris Anderson. And we're really underpinned by a multidisciplinary team who meets once a month. And our meetings are online. We bring cases and discuss anyone we've seen in clinic. And the meetings are attended by people from genetics, psychiatry, research, social sciences. So we really get the benefit of everyone's perspectives, which can vary quite considerably. So there are 2 main aspects to what we do. First, we see people with a personal or family history of psychiatric or neurodevelopmental disorders, and we provide discussions around genetic risk. Now, this can be helping someone to understand the genetic basis of their illness. It can be discussing risk to family members, including children, and it can involve preconception and perinatal risk counselling. This may or may not involve genetic testing because the service is about more than that. But I'll go on later to tell you a bit about the testing we've been doing. We also see people from the other side. So people who have been diagnosed with a genetic variant, quite often one of our copy number variants, and who want a discussion around the risk of developing mental health problems. And so we approach things from more than one angle. Now, working at the interface of psychiatry, genetics, and research is a privilege, but it also poses some challenges which have been quite interesting to encounter. This is a quickly developing field, and it can be quite difficult sometimes to work out how to interpret a genetic variant for an individual, because as you know, a lot of our research is done on a group basis. So trying to translate that into what that means for that one person is a challenge, but it's interesting, and it's also beneficial for that person. Our referrals for people with family or personal histories often come from psychiatry, but not always. And referrals from in the other direction, so from genetics, tend to involve people who've been diagnosed with a variant who wants some kind of discussion. And one thing I've noticed is that we obviously take a mental health history during appointments, and quite often we'll come across symptoms that we think may need input, but that person isn't necessarily under a psychiatrist. And in the NHS at the moment, there's quite a high threshold to get into secondary mental health services. So that can pose a bit of a challenge for how we help people going forward. And this really was where we come back to leaning on our MDT, because it's only by putting our heads together that sometimes we can sort the situation. A few years ago, during my PhD, I was examining the effect of neurodevelopmental CNVs. So it was 54 CNVs associated with intellectual disability, autism spectrum disorder, and developmental delay, although all of the what we would call schizophrenia CNVs are in that group too. And the clinic has played an integral role in delivering the protocol that we developed during my PhD. To tell you a little bit about the NCMH cohort, it's the National Centre for Mental Health. It mostly involves people with mental health disorders from across the board, but there are some controls in there too. And during the consent process, very similar to what David described in his presentation, we asked people, if we find a genetic variant that we think might be important for your health or that of your family, would you like to know? And 95% said yes. So we spent a considerable period of time working out how to approach this. And ultimately, we decided to return what the NHS would return if you had a genetic test and in the National Health Service. And that is CNVs which are considered to be pathogenic or likely pathogenic. The eagle-eyed people in the audience might note that there's 1 or 2 VUSs or variants of unknown significance in this list. They are there because they have specific indications. So, for example, the duplication on 16p1311 has a cardiac risk attached to it, which suggests that you might want to do some monitoring or investigations. So essentially, we ended up with a list of 39 what I would call returnable CNVs in the context of this project. So our research participants have had a research standard test. They have not had a test done in a clinically accredited lab. So anyone who wants to find out their result has to have a confirmatory test before we can deliver that. So we developed a process by which we contacted them in much the same way as David mentioned. He approached his participants and basically said, do you remember that you were asked this consent statement when you signed up to NCMH? We think we may have found something. Would you like to discuss it further? And so, as I said previously, 95% said yes to the original consent statement. And then, so when we've contacted people, we've brought them in for a first appointment where we've given them a bit of background as to what we mean by what we said in the letter, although we can't disclose the result at that stage. And at that appointment, we take a full psychiatric history. In the second appointment, then, if they wish to proceed, they have genetic counselling, although there's always someone from psychiatry and genetics at each appointment. And then they decide whether or not to have the confirmatory test. So I thought it might be nice to give you an update on how it went, because we've almost finished this, this cohort. So we started with 101 carriers of the 54 CNVs and pretty quickly lost 79 of them, either because the CNV wasn't on the returnable list, or they didn't reply, or perhaps they didn't consent to return of results. A further 7 went because some of them had died. One person already knew that they had a CNV, and 1 or 2 people either declined or just didn't attend their appointment. A further few were lost to follow-up or decided not to proceed, and then we ended up with 10 people, who 8 of which have completed the 3 appointments and results disclosure, and 2 are ongoing. And I thought I'd give you a little bit of a summary of some of the characteristics of the people we've seen, because I don't think we were expecting it to look quite like this. So the ages of the participants have been across a range, so 25 to 64, and it's been a 50-50 split between males and females. They have, so far, the people who've had result disclosure have been carrying 6 different CNVs. And one thing I think is quite interesting is that we would associate all of these CNVs with neurodevelopmental disorders, but the primary disorder in many of them was not neurodevelopmental at all, at least not how we would normally conceptualize it. So we've had people with post-traumatic stress disorder, with personality disorders. So I think that kind of brings home that you can carry these CNVs, but it doesn't necessarily mean what you'll develop will be neurodevelopmental in origin. So as I said, I feel quite strongly that stories bring this to life, and we've had really good feedback from the people we've seen so far. So I thought I'd end on two of our participants or patients. So I'll start off with Mr. Jones, who was a 63-year-old gentleman with a history of anxiety and depression. He's always felt different, especially when compared to his siblings, and some of them he feels may have excluded him. He's got many physical health problems, all being looked after by various different specialists. I won't read out the conditions, you can digest those for yourself. So Mr. Jones was a participant in the NCMH sample, and we identified a particular CNV, which was confirmed on confirmatory testing. So the clinical lab, these tests were all done by Jade Heath. They confirmed a 2.2 megabase loss at the 22q11.2 deletion region, which may explain his cluster of autoimmune disorders, possibly his psychiatric disorders. And I can't remember if I previously mentioned he also had hypocalcemia. So our lab uses these guidelines to interpret the pathogenicity of the CNVs. And this is a breakdown. So this is what Jade will bring to our MDT to explain to us how she's come to a pathogenic CNV rating. And so you can see how she's constructed that score. My final patient is Mr. Davis, who is a 32-year-old gentleman with depression, panic disorder, and PTSD. His physical history includes a duplex right kidney, hearing loss, and joint hypermobility. And he's got a family history of some people who've attempted suicide, ASD, and hearing loss. So much the same as the previous patient, Mr. Davis went through the National Centre for Mental Health and wanted to have a confirmatory test. This confirmed a 1.8 megabase copy gain at 17q12. And there's just a bit of an overview of some of the phenotypes associated with this CNV. Again, this is what Jade brought to our MDT to explain to us how she'd established the pathogenicity score. This one in particular involved a complete overlap of a triplet sensitive region. And we are conducting a more in-depth analysis of what our participants think about the service and whether they think it's a positive thing. Anecdotally, we can say that they've certainly given us positive feedback. And I've appreciated an explanation. And I think one thing that struck me is just how well that they grasp the concept of risk. And, it's quite an abstract concept, being able to explain the inheritance of psychiatric disorders, but they just get it. So in conclusion, I think that obviously translation of our psychiatric genetic research findings is really, really important. And this is a really good example of how we're doing it. It's not without its challenges. And I think that highlights the importance of your MDT working. As I said previously, patients really seem to value the opportunity for discussion and for learning more. And so I'll end there. I'm very happy to take questions.
Thanks, Kim. Excellent. So any quick questions for Kim? Either in the chat or please raise your hands. I'll ask you one.
Okay.
Which isn't an easy one, but what do you think? How would things differ or be equivalent if we were talking about single base mutations as opposed to CNVs? And do you envisage that being something that could be translated soon?
Do you mean highly penetrant recoding variants?
Yeah.
You're not talking common?
No, rare.
Well, I suppose the concept is the same in terms of their translation. I suppose there is less out there in terms of evidence. In terms, our ability to interpret them is going to be restricted by the lack of evidence. But the actual principles are, I think, pretty much the same. I suppose we are limited by the fact that some people have personal mutations, but yeah, it's possible.
Okay, brilliant. Well, if there's no questions, we'll move on to our final speaker. Thanks, Kim. The final speaker is very pleased to welcome Boris Chaumette, who may pronounce correct my pronunciation. But Boris is probably well known to many people. He's a French psychiatrist and leads the Centre for Rare Psychiatric Disorders in Paris. He's an associate professor of psychiatry at the Université Paris Cité, and is committed to developing genetic testing in psychiatry and has been instituting this in a clinical perspective for some time now. From a research perspective, he's exploring the genetics and epigenetics of particularly psychotic disorders and early onset psychotic disorders in addition, and also holds a position in McGill in Canada and has worked out there on developing some of this work as well. So Boris, thanks very much for joining us today and for speaking to us. Over to you.
Thank you, James. Thanks for the invitation. I'm very pleased to be with you today to present what we are trying to do in Paris for the patient. So, as James mentioned, so I'm leading the Center for Neuropsychiatric Disorders in St. Anne Hospital. And as Kim presents, we have both approach. One is taking care of patients who are already carrying a genetic defect. The other side is to be able to diagnose genetic defect in patients with psychiatric disorders. So if we want to refer to the genetic testing statement of the International Society of Psychiatric Genetics, everything is already put into the context of this statement. Let me explain you what I following from this statement with an example of the deletion of chromosome 22q11. So we know that these patients that carrying this deletion have a high risk of developing different psychiatric disorders along the time of their life. But the question is, how can we manage the treatment for this patient? Because if you look at the clinical practice recommendation that just came out this year from a multidisciplinary team, the need of different practitioners is not the same at different time points. For instance, you can see in psychiatry, there is a huge need of psychiatric care during adolescence, but there is also a large need of, for example, cardiological assessment or endocrinology assessment across life. So some CNV are clearly associated with other health problems, and the identification of this CNV may have clinical implication for general medical care. But I would like to demonstrate also that this care is also important for psychiatry. Let's talk about the clinical management of psychosis in this patient. We know that these patients are more resistant to typical and atypical antipsychotics. So most of the time we had to use clozapine to treat psychotic symptoms in these patients. Also, these patients are very prone of developing extrapyramidal side effects with antipsychotics, and they may be at risk of developing early forms of Parkinson's disorders. So clozapine is the treatment of choice for these patients. The problem is that clozapine can decrease the threshold for developing epilepsy, which is another risk for these disorders. So we have in the same time to carefully monitor EEG and also the calcium level, which is known to be an effect of the disorders. We can have hypocalcemia and we can worsen the epilepsy. So most of the time when I use clozapine for this patient, I have to use also an anticonvulsivant at the same time. In the same times, there is immunodeficiency due to the symptoms, so we have to carefully monitor white blood cells. So you immediately see that in this kind of condition, we have to develop multidisciplinary discussion between psychiatry and other specialty. Finally, rare disorders bring psychiatry closer to the rest of medicine. Let's talk about empowerment, because in the same genetic testing statement, it says that notification of pathogenic CNV in adults with major mental illness may help patients and their family to better understand and accept their diagnosis. In Paris, we developed two programs of psychoeducation, which is a PsyRare. The PsyRare program is addressed to the patient during adolescence to help them developing new skills during the transition between childhood and adulthood. And thanks to this program, we have a clear success on social functioning, coping abilities, and symptoms from this patient. And now this year, we are also developing a social skills training from adapted from UCLA, the PS program, which is specifically dedicated to a patient with genetic defect suffering from autistic feature. Because this patient also raised a lot of questions about the peer relationship. Should they share the information about their genetic defect to the friends, to their peers? How should they protect through the bullying, especially during adolescence? So this is a clear example of how we can do empowerment based on genetic knowledge. Another impact of CNV detection is the information about risk to a relative. So in most of the case, in 22q11 deletion, we can be very reassuring for the family because most of the time the deletion is de novo. But we also have questions sometimes when it's run in family or when a patient carrying a deletion wants to have a child. And this is not science fiction. Now we are proposing in a partnership with colleagues from Institut Imagine, it's a genetic center close to a hospital, to do prenatal or pre-implantation genetic diagnosis. So from a patient with a deletion 22q11, now we can have in vivo fecundations and selection of the embryos and implantation of embryos not carrying the deletion. So this is a real life. Of course, we have a ethical background for that, and it's a collegial discussion over time. The last point I would like to highlight is the interest for the patient about research. Patients really like research and they would like to contribute as much as possible. There is a conference every 2 years in Europe about the 22q11 to help spreading the research results. It's also an important time where researchers can come and advertise their research, and that could be very helpful to help recruiting research participants. But we are also moving to the next step now, and we are developing participative research. We are very close to a French association of patient and family carrying a 22q11 deletion. And together we design a project to develop a smartphone application for self-report of the symptoms. That was an idea of the families that want to monitor the transition between childhood and adolescence to be sure that they are not missing any symptoms. So that's something they come from the patient, and we are helping them to develop this kind of research. Research in these disorders is very important. As you know, as you mentioned before during the discussion, we know that these patients are at risk of developing psychotic disorders, especially schizophrenia, but also schizoaffective or delusional disorders. And you can see here the onset of psychosis in this patient. And there have been at least one trial, which is an open label trial, investigating the role of omega-3 as a preventive factor for onset of psychotic disorders. But much can be gained from this approach, that following longitudinally the patient and trying to develop treatment for prevention of psychosis. Two other examples that I'm sure you know. One is from James Walter's group, by the way. So it's a good way to explore the crosstalk between CNV and polygenic risk scores, because CNV have a difference in terms of phenotype. There is an incomplete penetrance or variable penetrance. And so polygenic risk score can also help to predict the risk of developing psychotic in this patient carrying a CNV. In the same time, you can also take into account this copy number variant to explore deeply the imaging phenotype and to work on subgroups. For instance, in the Enigma consortium, they compare a patient with 22q11 with and without psychosis, and they compare then these results to brain imaging data from schizophrenia and controls. And they saw that the same kind of difference are seen in patient 22q11 and psychosis and without psychosis compared to schizophrenia versus control. So it means that the risk for schizophrenia, at least in polygenic risk scores or in imaging data, are entangled with the risk of developing schizophrenia in the CNV patient. Let me talk about another example that was mentioned by Kim, the Prader-Willi syndrome. That's another rare disorders, 1 birth on 25,000, but we receive many of them, like we have around 50 now cases of patients with these disorders. And the clinical management is also very difficult because they have a lot of different conditions, and we have to manage carefully the psychotropes. For instance, we avoid antipsychotics because in these disorders, they have hyperphagia with obesity. And so when we absolutely need antipsychotics, we will favor aripiprazole, which is the antipsychotics which is less at risk of giving obesity. Another treatment is topiramate, which is not a treatment often used in psychiatry, but it's very interesting in this syndrome because it reduces hyperphagia. It also have an effect on behavioral problem, especially the temper tantrums and the self-harming behaviors. So we are proposing this treatment from epilepsy to rare disorders. Another point is to avoid benzodiazepine, for instance, because benzodiazepine can increase the risk of sleep apnea of this patient. And also the patient are sometimes referred to endocrinologists because of hypogonadism, and we have to discuss with them the use of testosterone, which can be very dangerous for aggressiveness of this patient. But inside this syndrome, there is different genetic defect. One is the deletion of the region 15q. Another one is a uniparental disomy, maternal disomy. And in this paper we recently published, we compare the presentation of the patient referred with deletion and disomy. And we saw that the behavioral and psychiatric patterns differ from one to another mutation, but also the efficiency and the tolerance of treatment by topiramate, with more side effects on the disomy group and less efficacy on the disomy group. So it's really inside the syndrome. The genetic defect can help us to understand why the treatment is not well tolerated. So I really believe that we are now moving from the gray part of psychiatry to a more colorful aspect. But the next step is clearly through genetics to be able to identify different kind of patients and to have clinical trial that is different for each patient. So maybe we are moving, thanks to genetic disorders, towards precision medicine. So the problem is today it's a rare disease day, and not all the psychiatrists are aware that behind psychiatric symptoms there is a rare disease. But rare diseases are very, very heterogeneous. There is 6,000 and more rare disorders identified, half of them having psychiatric or neurodevelopmental symptoms, most of them being genetics. And altogether, these rare disorders are many. And if you look at the number of rare disorders behind the diagnostic of schizophrenia, it's not only very rare, taken collectively. For instance, CNV in schizophrenia is around 1–2% of the cases. But the yield of diagnosis, molecular diagnosis, is increasing for patients with schizophrenia and neurodevelopmental disorders or resistant or early onset psychosis. The same for SNV. There is 3 recent publications showing that the molecular yield for schizophrenia is very important. I don't know any other field in psychiatry that have this number of success. If you do a MRI to every patient, you will not find 10% of abnormalities. But when you do whole genome sequencing or CNV screening, you have this kind of yield for your patient. In France, we now have a plan, which is France Médecine Genomique 2025, which is in 2 parts. First, we receive the patient and we can do RA-CGH to detect CNV. And using this RA-CGH, we detect around 9% of CNV in neurodevelopmental and resistant forms. Once we have if we don't have identify any CNV, we can perform whole genome sequencing in trios for what we call syndromic schizophrenia, which is defined by a lot of clinical criteria. And the yield is very high. It's about 1/3 of the patient. So it's a limited cohort, of course, because we filter the patient based on clinical criteria, but the yield is very impressive. Honestly, we were all very surprised when we saw this percentage of success in this plan. The problem is, if we highlight this success, is it convincing for the colleagues? Not so much, finally, because many colleagues remain reluctant to the implementation of genetic testing in psychiatry. And with Engage, which is a cost action, I call it with Franziska Degenhardt in Europe, we circulate a survey to detect the barrier of genetic testing and counseling in psychiatric colleagues, in clinical geneticists, in genetic counselor. And what we found is that the colleagues are very prone to offer genetic testing for neurodevelopmental disorders or neurological disorders, but less okay to provide genetic testing for major psychiatric disorders. And we are not talking about the large community of psychiatrists. We are talking about psychiatrists who knows about genetics. We are talking about genetic counselors or clinician geneticists. So it means that in the community, very few colleagues offer testing for major psychiatric disorders. And the type of genetic testing is very large. Honestly, I was surprised by the number of colleagues that are okay to provide whole exome and whole genome sequencing. The problem is that they can access to the test, but they don't provide the test for patients with psychiatric disorders. There is significant difference, of course, between Eastern, Northern, Southern, Western Europe, and it's depending on the covering by the National Health Insurance. Of course, the cost is a barrier, but the problem is that for major psychiatric disorders, the cost doesn't matter. When it's covering by the National Health Insurance, you don't see more colleagues okay to prescribe genetic testing. So it means that there is other reason for hesitance in implementing psychiatric testing. And we do a qualitative analysis from the survey showing that there is a lack of knowledge about genetic in psychiatry, low awareness, and believe that there is a lack of interpretative power of genetic testing in the context of diagnosis. Many colleagues say it's okay for research, it's not okay for diagnosis. And there is a lack of professional guidelines and protocols. So the last question of the questionnaire was, do you know about psychiatry genetics training course? Colleagues, only 11 of the colleagues say, yes, we do have this kind of training course in our institution. So it means that 90% of them do not have. And when we ask the question about should we offer that? Should we add a specialized curriculum in postgraduate training in the subject of psychiatry genetics? Most of the colleagues say yes, especially the psychiatrists who have the higher affirmation rates compared to other professions. So it means that if we really want to implement genetic testing, we have to convince the colleagues, but also to help them to train and to develop their ability to prescribe and interpret genetic testing. For that, we, with Christina Taninias, another colleague from Engage, she's in Sweden, we are having a course in the European Congress of Psychiatry, which is in March in Paris, so you're all welcome if you want to come to the beautiful city of Paris. We also know that sometimes rare disorders can be challenging to treat. So it's always important to be able to discuss with the colleagues. And for me, it's one of the points how to reach the colleagues. Many of them, they have seen one patient sometimes who has a rare disorders. And you can say, okay, this patient, I can help you to adapt the treatment. I can help you to empower the patient. And then you have several patients who are suffering from rare disorders that are not diagnosed. So with this approach, I can help them to convince doing genetic testing for the patient. So,
Boris,
yeah.
Oh,
no,
sorry, just in the interest of time, thank you very much. So I just want to open it up for questions, and I know that unfortunately I missed 2 people last time, so I'm going to come questions for Boris and for Kim, and then any general discussion points. Very welcome. Can I start by coming to Veronica? Veronica, did you want to ask anything?
Hi, do you hear me?
Yes, we can hear you.
Yeah, hi, it's Veronica from Paris. I am a psychiatry resident, and I have a question for Dr. Kendall about CNVs. So what about association of many CNVs? Is it frequent? Does it have an impact on like phenotype?
So are you speaking about anything, any phenotype in particular?
No, about like psychiatric phenotype.
psychiatric phenotypes. So there's established associations between copy number variants and disorders on the neurodevelopmental spectrum. So that will be intellectual disability, autism, ADHD, schizophrenia, and some versions of a schizoaffective disorder, also some versions of depression. They've got quite wide-ranging consequences for physical health too. If you drop me an email after this, I can send you some things to read if you want.
Okay, thank you.
That's okay.
Thanks, Veronica. John, Sabat, coming to you again.
Hey, so now having seen all of these presentations, of course, I have to start thinking about 17 different dimensions of healthcare for CNVs. One thing you know for certain is that, when you look at the broad phenotype of a CNV carrier, mental health is a big factor, diabetes, late onset dementia, early onset psychosis, obesity. So the genetics, not just rare variants, but common variants also, never points to specificity between risk alleles and psychiatric traits. You really have to be thinking in terms of broad healthcare across multiple clinical specialties. So in psychiatry, we're always asking, how does psychiatry use this information? And I keep thinking to myself, psychiatry is just one clinical specialty. What if you had this information at age 12 and you had it for interpretation across the lifespan? How could healthcare services be changed in a way where you could use this information across mental health and other clinical specialties throughout the lifespan?
I mean, I think it's a really good question. It's one that we discussed in preparation for today. So there's two perspectives here. One is looking at genomic risk factors in those with a psychiatric disorder, but then there's also those with the genomic risk factor and what services they can access. And it's a tricky question, I think, for health services, but I'll come to Boris, perhaps you first, and then give David and Kim a chance to answer as well.
Yeah, so the first thing is, thanks, Jonathan, for the question. It's crucial for psychiatry. I think we need to change our mind about the nosography, because now we have defined diagnostic categorical diagnosis. But now with this model, we are totally changing the frontiers. The boundaries are totally changed by that. So let's talk about patient with this genetic defect, not with this psychiatric disorders in itself. And we will change also our mind about the treatment, because what we are doing now is we are treating patients with symptomatic treatment. We're not treating them with knowledge about etiology. So I think it's totally mind-changing.
Okay. David, Kim, do you want to add anything to that?
I've got nothing to add to what Boris said in the interest of time.
Yeah, just comment. I'm a big fan of the movement towards newborn screening and exome or genome sequencing in newborn screening, and these would be important rare genetic diseases to identify immediately in the neonatal period for early developmental intervention. So, yeah,
but I think the pleiotropic nature that Jonathan touched on of these as genomic risk factors presents real challenges to the design of health services and their delivery, and it is something that we need to think about more. Some have gone down the route of having clinics for people with particular CNVs, but I don't think that's sustainable really as we find more and more variants that increase risk, nor is it realistic to expect one clinician to treat the range of disorders. So it means working together, I think, and multidisciplinary team that we formulated and others have done, I think, is one way around that. Okay, thanks. I'm going to come next to Dr. Daniel Moreno de Luca.
Thanks, everyone. Fantastic talks. And I was really struck by the similarity of efforts that are happening in several lines. How do we reconcile those efforts in a way that can be generalized to people with many different rare genetic conditions from the top down? And how do we better make the case for insurance companies and healthcare systems to show them that using this information from the get-go can allow us to move into preventive versus reactive healthcare? So my two questions are mostly focused on top-down approaches to homogenize what we're doing and to make a good argument for healthcare systems to show the value of these.
Okay, thanks very much. And I think it's a really important observation that there is such convergence across the three presentations and the services that have been developed on the back of that, which wasn't by intention, although you were aware of each other's work, I think. But has anyone got, I think it's an important point Daniel makes, has anyone got a comment about that?
So I think that we certainly learn from each other, and that's important to make these kind of networks. I suppose our approaches do need to differ slightly because our health systems vary so considerably. So I think it's important that we sort of make these connections and learn, but accept that we might need to adapt.
And I think certainly in the UK, and I think probably this applies in France as well, it's the commissioners that we've got to convince to invest in the genomic testing, and the ways we've done that is to talk about the multimorbidity that you see with these disorders. It's probably a different conversation with insurers, but I don't know, David, if you've got any experience of those conversations or any views about how that is best taken forward.
Yeah, I mean, I had an easy situation at Geisinger since we had our own health plan and they were open to learning about new technology, and we could provide them both published data and our unpublished result, and they would make really good scientific and medical decisions. So they were early to approve exome sequencing for all children with unexplained developmental delay, intellectual disability, autism, epilepsy, and then adults with psychiatric conditions. They are willing to post their coverage policies publicly on the website and make them available to other payers. And we've encouraged people to take the Geisinger health plan coverage policy and try to use that to convince their own insurance company in the US. It's a slow process to bring insurance companies around.
Yeah, but certainly I think benchmarking against other providers is something we've found is of use, and also making the case that within mental health and psychiatry, we don't want to be left behind, and there needs to be parity of this provision across physical health and mental health conditions. Okay, thanks, Daniel. Coming lastly to Benjamin Laplace.
Good evening, everyone. Hello. Thank you very much for your great speech. Very inspiring. I have a question for Dr. Boris Chaumette. I wanted to know his thoughts about clozapine in 22q11 deletion and psychosis management, because, as you said, those patients are maybe more prone to respond to clozapine, but we know that this treatment is prescribed after the failure of 2 other antipsychotics. Do you think that maybe recommendations for those kind of patients might evolve and recommend us to go to clozapine earlier? Is it something that might be possible?
Based on the latest consensus, open consensus on that, there is no clear idea of going directly to clozapine. But on my side, when I saw the patient, say if the patient doesn't respond to aripiprazole or risperidone, I'm quickly switch to clozapine, for instance. Maybe we should take into account that maybe you should go faster to clozapine, but there is some patients, very few I should say, that are were only with aripiprazole, and it's less there is less constraint of using aripiprazole, for instance, than clozapine in terms of follow-up. So I will not maybe say to go directly to clozapine, but just to think quick to this treatment.
Okay, to keep it in mind earlier and to be ready to use it. Okay, thank you very much for this answer, very clear. And I also had a thought about what you said about the low awareness from psychiatrists, and that might explain the low use of genetics in psychiatry. And I think that is an obvious thing we made. I think research about psychiatrist acceptability of pharmacogenetics here in France, as you know, and we had the same kind of results. People were not enough trained or not enough informed to use this kind of tool well. So I think it's one of the big challenges.
Yeah, thanks a lot. Just a quick answer. In the survey we conduct in Europe, only 15% of the colleagues order pharmacogenetic tests.
Yes.
So you see, it's the gap is huge.
Yes, indeed, totally. I can't more agree. Okay, thank you very much.
Thank you.
Thank you. Okay, so we're 7 minutes over now, but I am going to give Carolina Cappi chance to ask because yeah, we wanted to encourage questions, and so I don't want to finish before we've got that chance. So Carolina, over to you.
Thank you very much, James. I'm Carolina from Mount Sinai Hospital. I think that my question is more for Boris, that I want when you say like not treat diagnosis, but treat people that have these copy number variations. So, and I just wonder, what is the environment impact of that? How will control that? And if it's like you know, for the common variations, you have more like it's a polygenic, and then I just think that the environment will have a lot of impact on that. And also, what about this translation for the other countries, like diverse ethnicity? What is your thoughts about that?
Yeah, for ethnicity, it's more relevant for polymorphisms and rare genetic defects, which are some most clear-cut things like 22q11, for instance. Yes, of course, environmental factors play a lot, and I'm totally convinced of that. I'm working on epigenetics, so of course. And I think that there is several ways to develop disorders. One is through genetic defect, which is very clear and can catch the variants. One other way could be through, for instance, cannabis. We know that cannabis is playing a lot of a huge role on the onset of psychosis, for instance. And cannabis alone is not maybe a risk factor. Maybe cannabis has to be entangled with genetic factors like polymorphism and so. So the question is not easy to answer about gene and environment, but at least with rare disorders, we are taking one range of the disorders, saying that for this patient, we know I would say a huge word, but the cause of the disorders. And that's why we are able to do subgroups and to develop treatment specifically for this patient.
Okay, thank you.
Thank you, and thank you everyone for engaging in the talks. And I'll just finish by again thanking the speakers and the PGC and Catherine Lewis for inviting us to speak today. So cheers everyone, hope to catch up soon. All the best.
Thank you, bye-bye.
Thanks.